everybody in the ecosystem, right up to the principal secretary for governance, real-time data, timely data, data which is of good quality, good integrity and timely is something that we are trying to work with.
Today we have with us Mr. Hardeep Singh Bambrah, Vice President, Head Aspirational Districts Collaborative Health at Piramal Swasthya Management and Research Institute. Mr. Hardeep heads the public health interventions for the foundation under the Aspirational Districts Collaborative. He was a business manager in his previous avatar, having spent 14 years in the industry and joined Piramal Swasthya in 2014 to live his dream of working in the social sector. In his years with Piramal Swasthya, he has led the conceptualization and delivery of several large-scale public health projects in partnerships with NITI Aayog, Govt of Assam, Govt of Rajasthan, several NGOs and CSR partners across the country. An MBA by qualification, Hardeep's passion and strengths are in creating and implementing strategies for impact, building strong and resilient result-oriented teams, leading large-scale projects, and forging strong partnerships. Thank you so much for joining us today, sir, and I really look forward to our conversation.
Thank you so much, Isha. It's a pleasure. Thank you so much for the nice introduction as well. Thank you.
Thank you. So to begin with, I would like to ask that what are some of the key programs that Piramal Swasthya has undertaken to make primary healthcare affordable, accessible, and available to all?
So as a foundation, and when I say the foundation, I mean the Piramal Foundation, which has three verticals. The Piramal Swasthya happens to be the health vertical of the Piramal Foundation, and then we have Piramal Education and the Piramal Sarvajal. And as the name suggests, Piramal Swasthya works on public health. We are an NGO, and the basic philosophy that we work with are broadly two. Number one, we believe that impact at scale can be achieved by working with the government only. Therefore, we ensure that all our efforts are always complementing and supplementing the efforts of the governments. And that's number one. Number two, we believe in the power of innovation. We believe that innovation has the power to change basic problems at scale. So therefore, while we start small, when we innovate, we always think big. And it is with this philosophy that we have always been working in the country. Piramal Swasthya was born in the year 2007. And we believe that bringing about change through innovation can probably be done through a three-stage process, how we take it. So first we look at a problem, a pressing problem in the community in public health. We try and innovate a solution around it. And of course, pilot a solution at a small scale. That's step one. And then we would want to demonstrate that solution at a relatively larger scale, say a district, for example. And then finally, we would want to scale it up, provided the three stages are successful, that is. Now, with this background in mind and this three-stage process that I spoke about, I would also like to share that even the foundation's investments are embedded, and we have a philosophy around the investments for the three stages. So Piramal Foundation's, most of the investments or the majority of the investments go into stage one and stage two. So the innovations are always invariably funded by the foundation, and most of the work around the demonstration as well. But we believe that if an innovation is successful, if it has been demonstrated at a reasonable scale, the ecosystem then has the ability to actually take it up, and we get the fundings from other sources as well. And I would want to share a couple of examples to make that point, and that also talks about the journey of Piramal Swasthya as an NGO, so to say, post its birth in 2007. So if we look back at 2007, when the organization was born, we started thinking as to what is the first problem in public health that we would want to try and solve. And if you would just think back about more than a decade and a half back, there weren't as many sub centers or primary healthcare centers as they are today at the community level. Accessibility, availability, and affordability of healthcare services, as we call them, was relatively very, very poor compared to what it is today, although there still is a lot to be desired. But around 2007 to 10, it was relatively much worse than it is today. So just imagine a person, for example, a villager living in a remote district, say, for example, in Andhra Pradesh. And, this guy, if he is sick, or if his wife, for example, needs an antenatal care checkup, he or she would have to travel kilometers, sometimes 30, 40 kilometers to get that even basic primary healthcare treatment, etc. So we started thinking around this beneficiary and said that how do we innovate to solve this problem? Start small, but think big. And that's how the 104 Health Helpline, for example, was born. We were the organization, the first organization that piloted this model. It was almost at scale because we did the first 104 Health Helpline in partnership with Government of Andhra Pradesh, which was a statewide project. That's number one. Number two, again in partnership with the Government of Andhra Pradesh, we started off the first large-scale mobile medical unit project on a PPP mode, again with the Government of Andhra Pradesh, wherein a team of paramedics led by a doctor would go to the remotest geographies, areas like the ones I said where this beneficiary lives, which is more than at least 3 kilometers away from the nearest health center, and provide primary healthcare services. Now, this same person who would earlier have to travel 20 kilometers, 30 kilometers, anything beyond 3 kilometers to get even a basic paracetamol, actually, if he's sick, could number one, pick up a phone and call up the health helpline and get validated medical advice. He could even speak to a doctor, apart from speaking to a counselor or a paramedic as the requirement may be. Plus, every month there is also a mobile medical unit which comes on a fixed day to his village at his doorstep to provide him the services. So therefore, especially for diseases like chronic diseases like hypertension and diabetes, where you need regular supply of medicine, you need to get your BP and sugar, etc. checked up every month, those problems are taken care of. Similarly, antenatal checkups. So if his wife is pregnant and he then does not have to go, more than 3 or 4 or 10 or 20 kilometers away to get that done. In fact, the doctor and the paramedics are coming to his doorstep, and he can get the 4 ANC checkups mandated. He can get the pregnant ladies sugar checked up on the spot, the hemoglobin checked up on the spot, and services can be provided. So while we did this in Andhra Pradesh and started off in Andhra Pradesh, these projects or these models have actually gone through the 3 stages that I spoke about in the beginning. So while we piloted it in Andhra Pradesh, wouldn't say that it was really a small scale pilot. It was demonstration at quite a scale. Today, these projects have been scaled up across the country and they have been taken up at scale by the ecosystem itself. Mobile medical units on a PPP mode, 104 health helplines on a PPP mode are now funded by NHM every year under the PIP, and multiple organizations are doing it. So it is not necessary for a Piramal Swasthya to be there to be able to do that today. Although we still continue to do a lot of 104 health helplines across more than 7 states and also mobile medical units. But we look at these projects now as our platforms for innovation. We would always want to continue to do these direct implementation projects, like we call them, directly going to the communities and serving them, because these are the projects which give us the ground reality. This is what keeps us grounded to the communities, and these projects also act as our ears and eyes with the communities, through which we can then innovate and learn and innovate further. And currently we have moved on from direct implementation, like I said. While we continue to do the 104 health helplines, we also do telemedicine, a lot of telemedicine projects across the country. We have also moved into health system strengthening in our work, for example, in the aspirational districts. We have done a lot of innovations around technology, also leveraging these mobile medical units as a pilot. And these mobile medical units and 104 health helplines have shown a lot of beautiful impact. Just to share some numbers, since at the beginning I said that this beneficiary would have to travel tens of kilometers to get a service, he would lose out on a lot of cash, he would lose out on the income for the day, and of course he would have to shell out a lot of money. So the out-of-pocket expenditure would be very high. But given these projects, and we did a third-party assessment in the project which we did in Andhra Pradesh, the out-of-pocket expenditure actually came down from 396 rupees per month to as less as rupees 80 per month. Also, there was significant decrease in the levels of hypertension and diabetes of the identified beneficiaries who had at least more than 2 visits in the mobile medical units. So all in all, these are beautiful innovation grounds for us, and we continue to innovate with them. Isha.
Thank you for sharing the entire journey and philosophy of Piramal Swasthya and the three-stage processes that you have mentioned. And I think this entire mobile medical unit is a very innovative idea because it provides
Yeah,
doorstep delivery and services which are very essential, especially in some of the remotest geographies of our country. So there are
yeah.
some wonderful initiatives that you're working on. So thank you for sharing that. And so to move further and dive in a little deeper, I would like to ask that Piramal Swasthya worked on the Aspirational Districts Transformation Program to improve the health and nutrition indicators in 25 districts across 7 states. So could you also elaborate on that?
Yeah, absolutely. The Aspirational Districts project is actually very close to our hearts. Like I said, going back in the journey again, the first problem in public health that we tried to solve was the problem of accessibility, availability, and affordability. And to do that, we innovated on a model which is more of a direct implementation model. So Piramal Swasthya as an organization has directly implemented a lot of projects, large scale MMU projects, 104 health helplines across several states in the country today. And while we were doing that, we also realized, like I said, that it had gone through this three-stage project. Today, the ecosystem has taken up the innovations and it's being implemented at scale. So therefore, around 2013-14, we started asking the question as to what is the second level of problem or challenge that we would like to take up in the public healthcare space to try and innovate and solve. And we realized that on one hand, while Piramal Swasthya's strength was implementing at scale, implementing large scale public health projects at scale, working with the governments, we realized that this was not really the case with the governments. One of the biggest challenges which the governments face is that while on one hand the policies and the SOPs are excellent, very beautifully designed, however, unfortunately, they are centrally designed, but they have to be implemented locally, which leads to a lot of challenges. And then, as we all know, India is a very diverse country, huge country. Scale is a big problem. Demographic challenges are a problem. Diversity in itself is a big challenge to kind of overcome. So we said that why not try and help the government facilitate implement or help them implement better, because that's what our skills are. And this was the philosophy, and this was how the partnership with NITI Aayog was born under the Aspirational Districts Transformation Project. As you know, these aspirational districts are at the bottom of the heap, so to say, in the country. 112 districts across the country. And the overall HDI index, if you would see, while India ranks at about 131 out of 188 countries, just the fact that if these 112 aspirational districts were a separate country, they would rank somewhere around 180 out of 188 countries. So to say, there are two Indias. There is a second India within an India, which somehow has not been able to, so to say, take the advantage of the growth story of India and continue to be vulnerable and marginalized. Uh, Therefore, we partnered with NITI Aayog with the philosophy that we would handhold the districts to implement better. We would work with them at the ground level and help them implement better to improve outcomes around health and nutrition, for which we placed teams on the ground. And once again, through these teams, we looked at the districts as a unit of change, and had did multiple rounds of innovations and studies in these grounds, and some of those models have again been scaled up. Broadly, if I were to summarize the work that we did under the aspirational districts, there were four themes that we had worked on. Number one was that we took up facility strengthening in a big way. When I say facility strengthening, we took up gap assessments to helping the districts strengthen their facilities right from the subcenter level to the primary health center level to the FRUs or the first referral units, ensuring that, for example, the FRUs are operational, the blood banks are operational, the labor room protocols, etc., are being followed, equipments are in place, and so on and so forth. The second theme that we worked on, under this program was around capacity building. And within capacity building, we not just took up the capacity building in terms of technical elements of the frontline health workers, we did a lot of work around supportive supervision for the supervisors of the frontline workers. And the third element or the third theme that we worked under was helping strengthen critical schemes implementation through a process of business process reengineering. So we took up critical schemes, for example, like the Pradhan Mantri Matritva Vandana Yojana, where a pregnant lady gets about 6,000 rupees if she goes through a certain process. But we had seen that the uptake of the scheme and the actual beneficiary utilization was very less. So we took up certain such schemes and helped the government improve the implementation of those schemes. And the last but not the least, where we had a lot of learnings from, the fourth theme was around demand generation and working with the communities and working with progressive community leaders like the Panchayati Raj at the villages. We also did a lot of work with faith-based leaders to drive a change on the ground, social behavior change communication. And we also looked at, the deeper social issues which were causing some of the public health challenges. And as we move ahead, probably I will share some of those experience as well.
Thanks for sharing. And I think you have done it brilliantly, that how you have used your skill set, that's something that you do better in strengthening the entire ecosystem of the government. We are partnering with the government and NITI Aayog, and to basically to strengthen the entire landscape of healthcare in India. So that's really commendable, and thanks for that. So to move further, I would like to ask that what work has Piramal Swasthya done to build the system's internal capacity to produce reliable and actionable data, and promoting a culture of data as well?
Yeah. So like I had said in the beginning, we actually leveraged the mobile medical units and the 104 health helplines that we had been doing at scale to also do a lot of innovation around technology. And while we were doing these projects, we put up technology solutions to create electronic health records, to create dashboards, etc. But we also realized that we had siloed systems even within the organization. So I'll just explain with an example. In the state of example, Assam, for example, we have mobile medical units that we do for the government of Assam. We also do a 104 health helpline. And we also do an MCTS, or a mother and child tracking system helpline for pregnant women. Now, a beneficiary, who, if he or she visits the mobile medical units, a unique ID and health record gets generated for that beneficiary. Now, the same beneficiary, if he or she calls up the 104 health helpline, a different ID gets created. And same also for the MCTS application. So what we did first was we tried to bring our house in order, create a unified electronic health ID for the beneficiaries and an electronic health record for all our internal beneficiaries for a start. And while we were doing this, we also realized that similar problem is also there in the government public health system. And just to take an example, a pregnant lady, say in a district like Baksa in Assam today, when she gets herself registered in the public health system under a pregnancy, her data gets captured under a reproductive child health portal, which is the RCH portal. Now, if the same lady has an issue related to non-communicable diseases or hypertension, diabetes, or she gets screened under a program, the data would probably get captured under the NCD app, which would be a completely siloed and different data. Different unique IDs would be created and different electronic health records, so to say, would be created. And now the same beneficiary, if today she takes a OPD consultation on a eSanjeevani OPD platform, for example, again, a unique ID and a unique health record gets created. So systems everywhere were very, very siloed, and this does not help in terms of good governance. This does not help in terms of creating good data, quality data, timely data for good decision making, and stuff like that. So what we have done over the past 4 to 5 years is that we have developed an technology backbone, which we have called as Amrit. And Amrit stands for Accessible Medical Records via Integrated Technologies. And what Amrit in simple terms does is that it has the capability to act as a backbone and unify different disparate applications and systems, bring them together and create a single unified health record for the beneficiary with a single ID. And this is something that we are in the process of piloting in the state of Assam today, with the government of Assam in partnership with them, and also in the state of Bihar in partnership with the government of Bihar. And this is in the first stage, so to say, in our 3-stage process at the pilot process. Very soon, maybe within this year or next year, we would want to pilot and demonstrate this in at least 1 to 2 districts in at least 4 to 5 states. And then basis those learnings, we would like to scale it up. Essentially, the vision is that we would want to do our small part in helping India achieve the vision of unified IDs and the vision that National Digital Health Mission talks about. So that's the work that we are doing on the technology space, so to say.
And I think it's wonderful because nowadays it's extremely essential to integrate technology across all our interventions. It basically makes the entire program more effective, and we can reach to more people by leveraging the technology, and especially data, because data plays a very crucial role either in assessing something or delivering a program or implementation. So I think that's some great work that you have been doing there.
Absolutely. And it also helps in better decision making. So we
Definitely.
are looking at various levels, how to make the life of the ASHA, for example, easier, how to make the life of an ANM easier, everybody in the ecosystem, right up to the principal secretary for governance, real-time data, timely data, data which is of good quality, good integrity and timely is something that we are trying to work with.
Right. And it's not in silos that it becomes difficult to, assess what is happening at what front. You have unified it so that it becomes easier as well to take a decision accordingly.
Absolutely.
All right. So to move forward, what are the key provisions of the Aspirational Districts Collaborative and what is its impact on the society?
Yes. While we started off working with NITI Aayog in the aspirational districts, for the first 3.5 years or so, that is since 2018 that we got into the partnership, we had been working in 25 out of the 112 districts. So one of the things that we realized was that Piramal Foundation has always looked at India as a unit of change, and we realized that working in only 25 of those districts was actually not helping us in our vision. We really needed to expand to all 112 districts. And like I already said, these 112 districts are most marginalized districts in the country. They are total about a population of 180 million, which is 15% of India's population. And if these districts don't do well, India's growth story does not come out, and India would always struggle to achieve the HDI goals and the SDG goals. So therefore it was very logical for us that we have to expand from 25 to 112 districts. But the how part of it was the critical question. How do we do that? In the first 3.5 years when we worked in the 25 districts, we had people on the ground right up to the block level, facilitating implementation, supporting the district frontline workers and their supervisors and the district health teams implement better. But we started asking, is this model good enough for a scale up, or do we need to improvise? Number one. Number two, while we were working in these 25 districts, we also piloted a lot of models under the 4 themes that I've just spoken about a little while back. And we realized that we had done the demonstration and these models were scalable today. So therefore, probably we don't need as many people on the ground in terms of HR. And that also helps makes the model more sustainable. We did not really want to create a parallel system, of our people also working on the ground along with the health system. But then the question was that what are the levers that we can drive? So we looked back at the 3.5 years, and there were certain critical learnings from the ground. So for example, I'll just make my point with a couple of examples. In one of the districts in UP, we realized that early breastfeeding or timely, it's important and critical that breastfeeding within 1 month of delivery is very, very critical. 1 hour of delivery is very, very critical. And that was not happening. And that was a challenge. When we really dug deep into the issue, we realized that there was a deeper social issue which was leading to this problem. And the fact was that because of their religious practices in that community, a certain religious verse from the religious scripture was supposed to be read to the lady after delivery before she can, feed the baby. When we, engaged with the faith-based leader there, when we engaged with the religious leader there, we realized that they were actually very progressive, and they agreed that a lady could do that. And it need not necessarily have to be a faith-based leader. So they trained the community women to do that activity. Post that, there was a dramatic increase in the proportion of children that were breastfed within 1 hour of delivery. So this was one example. The other example is a very recent example from our experience working on vaccine hesitancy. And this example is from Rajasthan. where an entire community, an entire village was not getting themselves vaccinated because of the obvious stigma around vaccination, the fear around vaccination, adverse effects, etc. So when we engaged with the Panchayati Raj president, the Sarpanch of the village, and we were able to convince him that this is important, what he did was he actually got himself vaccinated at the community hall where people could see him getting vaccinated. We were able to create a video of that event. We were also able to create a video of the Sarpanch actually giving out a message to the community saying that this is an important activity and please take it up. It was an appeal by the Gram Panchayat president, which was then disseminated across the village through social media. Post this, over the next 7 days, more than 600 people who were eligible for vaccination in the village actually came up and got themselves vaccinated. We actually had to conduct a camp to do that. So the realization was that there are progressive leaders within the community whom, if we are able to identify, work with, and tap, we can actually address the deeper social issues which are leading to some of the public health challenges. So this was one. So we said that probably when we are going to scale up the work in the aspirational districts, we must start working more, getting more engaged with these progressive community leaders at all 112 districts. So that was number one. Number two is an example around convergence. I'll take the example of the PMVY, which I just spoke about, the Pradhan Mantri Matritva Vandana Yojana, which is a scheme run by the Women and Child Department, where a pregnant lady gets about 5,000 to 6,000 rupees if she gets herself registered for pregnancy, if she gets herself checked for ANC checkup, if she gets an institutional delivery, and then gets the required immunization on time. However, the challenge was that while this scheme, the money comes from the Women and Child Department, the data of whether the ANC checkups have happened, the data and the inputs around whether the institutional delivery has happened actually comes from the health department. So there are two different departments who have to come and sit together and work to ensure that the pregnant woman gets what she's supposed to get, and that in the government system sometimes becomes a challenge. But when we were able to sit with both the departments, take the help of the district collector, get them on board into a common forum, and actually, kind of re-engineer the process through this was happening, we saw that in districts from 30 to 40% disbursement of the money, it went up to 70 to 80%. So therefore, we realized that if we are really able to get different departments, different ministries to sit together and solve problems for each other, we can have a profound impact on the way that schemes are being delivered on the ground. It also had a profound impact on the way that funds were being utilized, for example. And the simple example was, for example, there were certain Anganwadi centers in villages which were dilapidated, not in a working condition, because of which lot of village health, nutrition, sanitation days, etc., were not being able to be conducted there. Now the VHSND is supposed to be conducted by the WCD ministry and the health ministry, which is the Asha ANM and the Anganwadi workers coming together. But in certain cases, when we got departments to sit together, we realized that the Panchayati Raj department had certain funds which could be used to repair the Anganwadi center, while the health department and the women and child department did not have. So while these are anecdotal, stories which came up and solutions which came up, we realized that convergence as a pillar has a big, big strength and a big power to drive about change at the community level. And therefore, the entire program design of Aspirational District Collaborative is actually based on two pillars of collaboration and convergence. And we are saying that we are going to collaborate with hyperlocal collaboratives. And for that purpose, we have identified 6 channels to start with. And these 6 channels are the Panchayati Raj institutions, the faith-based leaders, which I spoke about, the tribal leaders, the local NGOs. Hyperlocal NGOs can do a lot of good work if we are actually able to engage with them because they belong to that community.
Right.
Then the students and the volunteers from the community, the youth volunteers from the community have a lot of power to drive change. The self-help groups and also the local media. We have started work on this already. We have built a channel of more than 5,000 to 6,000 local collaborators already. And we are in the process of strengthening this channel as we move on. So that's number one. And also in terms of convergence, like I spoke about, we have started work at the districts in helping the different ministries to come together to create forums for that and then take the developmental agenda to these forums so that ministries start looking at each other as, as helping and a support force to each other to drive schemes and improve the health, nutrition, and mutual outcomes, whatever that they would want to work on. So that's the philosophy behind the Aspirational Districts Collaborative.
Right. Thanks for sharing those examples because they made us realize the kind of power, the power of collaboration and convergence to make any program more effective. And as you have mentioned, it's important to leverage each other's expertise. One player will be, expert in some field, the other will not be. As you have mentioned about the funds part for the department, Women and Child Development Department. So there are lots of examples like that, and it's also very crucial to take people's participation in. It's very important because without them we won't be able to deliver any program in their ecosystem. So to fight this stigma, all the societal and complex problem, it's important, as you have given the example of the faith leaders, how do we nudge people to bring so that they can
Yes.
work in their own ecosystem. So I think that's great. And as you have also mentioned about convergence, collaboration, and partnerships, so lastly I would like to ask that since Piramal Swasthya has been working in a lot of different models of partnerships, so, what are the various partnerships and engagement models that you have adopted to expand your reach and increase the scope of impact for healthcare services?
Yeah, sure. So I think a couple of them I have already touched. So we are
Right.
looking broadly, we look at partnerships at three levels. So there's Samaj, Sarkar, and Bazaar, if I may put it that way. So Samaj is something that we are going to take up in a big way going ahead. And I've spoken about that. The across the 112 district, we would like to collaborate and work with hyper local collaborators, identify these progressive leaders within the community, through which we can then drive change, and especially look at those deeper social issues, which are kind of a challenge towards meeting those social sector outcomes. And that's number one. Number two, partnering with the government is always a philosophy that we have worked with. We will continue to work on that. We have engagements, very deep engagements with the Ministry of Tribal Affairs, for example, with the Ministry of Health, and of course, NITI Aayog, with whom we work very closely in these aspirational districts. But the third level, which is the market, or the CSR organizations, so to say, the philanthropic organizations, the foundations, is something that we would want to get into more stronger partnerships, especially for these 112 aspirational districts, or the bazaar as we call that in the Samaj Sarkar Bazaar parlance. Now, just to give you a hint of how things are, while these 112 aspirational districts are at the bottom of the heap, while these districts have a population of 180 million, which is about 15% of India's population, all of us know that they need to do better if India has to do better. But unfortunately, we had done a recent study and we found that less than 3% of the total CSR funds in the country actually go to these districts. So the next level of challenge, or the next level of partnerships we would also like to get into, is to try and see that a lion's share of investments in the CSR space also comes into these 112 districts. Also investments in terms of efforts, investment in terms of knowledge partnerships, technical partnerships should come and flow into these 112 districts. And in this regard, I think the Aspirational District Collaborative is a beautiful platform that can be leveraged. So Piramal Foundation is investing its money through Piramal Swasthya in the 112 districts to create this platform. So we have people on the ground, we have people in all 112 districts working across these districts. We are in the process of creating a very strong local collaboration with the 6 channels that we spoke about. And we would want to welcome partnerships to build on top of this platform. So if we look at, for example, this platform as a pizza base, we would like to add toppings to this pizza base so that we can leverage each other's strengths to drive change in these 112 districts. So that's how we are looking at collaboration and the next level of engagement for these districts. Isha.
Thank you so much. And I think that the thoughts and learnings and experience that you have shared along with the entire journey of Piramal Swasthya and how you have integrated, as we have already discussed, data and technology, you have kept it at forefront of all your interventions to make it more effective to reach till the last mile of the society. I think the kind of solutions that you are working on are very innovative and they are very effective in the long run. They are more sustainable, if I use that word. So I think thank you so much for sharing the entire journey, and that brings our interview to a close. So thank you so much for joining us today. It was an absolute pleasure interacting with you. Thank you.
Thank you so much, Isha. Pleasure was all mine. Look forward to connect with you again. Thank you.